Right, well, welcome everybody. It's great to see you all here on this webinar. It's an important webinar because we're halfway through the TGA rescheduling process, which is a long and arduous process. The delegate came out with an interim decision against rescheduling, but what the delegate had to do was state his reasons, his or her reasons, and that gives us an ability now to go back and respond to each issue that the delegate has. And I think our case is pretty strong. So we've got everything to play for on this one. I'm delighted to have Professor David Nutt with us today. Many of you will have seen David speak at webinars that we've organised. David is also on the faculty for our certificate in psychedelic-assisted therapies. He's head of neuropsychopharmacology at Imperial College London. He's also in charge of their Psychedelic Research Centre, which is one of the first centres of excellence in psychedelic research in the world. And without embarrassing David, he's also one of the leaders globally in the research behind understanding the impact of psychedelic-assisted therapies and psychedelic medicines on the brain. David arrived in Australia yesterday, and he's here for a tour which involves Byron, Canberra, Sydney and Melbourne, where David will be speaking at public events about these therapies, but also meeting with regulators, politicians and key stakeholder groups. So David, we're delighted that you could make the trip over here.
Peter, I'm delighted to be here. It's been 3 years. I think this was planned before COVID, wasn't it? And it's...
It was planned before COVID.
Good to be here.
All right, look, but before we get into the detail of rescheduling and the response we've had to date and what we need to do going forward, I think it's really important that we just sit back and realise why this process is so important. And to do that, we've got a very short 4-minute video which we've just released. Some of you may have already seen it. It does involve comments about suicide. So for any of you who are uncomfortable with somebody talking about suicide, you may just want to take a bit of a break for 4 minutes and go and get a cup of coffee or whatever. But with that, Scott, you might start the video.
I just want to make a change so other people don't have to suffer. I have my daughter who's lost her dad, and she can never replace him. I'm here today to hand deliver a personally written letter from myself, Vanessa, in the hope of requesting a personal meeting with Anthony Albanese in trying to make a change with the TGA regarding psychedelic-assisted therapy. Born and bred in the inner west of Sydney, my husband Franco was a successful businessman who loved his family. We were married for 30 wonderful years and spent 11 of them raising our beautiful daughter Zara. On the 5th of April 2018, Franco, who had rarely ever been ill, wakes up to tell me he needs to see a doctor urgently. Upon his first session, Franco was diagnosed with a severe form of clinical depression. What follows over the coming 3 years is a further 7 hospitalizations, totaling 19 months in hospital, where he was administered a staggering 96 ECTs, 24 transcranial magnetic stimulations, and prescribed 19 different antidepressants and antipsychotic drugs. This was Franco's reality, and this remains the reality for the thousands of Australians suffering from treatment-resistant mental illness today. I began to feel reassured when I heard of the remarkable overseas progress of psychedelic therapies within treatment-resistant populations, Even more promising was that these positive results were occurring after just 2 to 3 medicinal sessions alongside a short course of psychotherapy. All up, Franco spent over a year and a half of his life in hospital, was administered shock therapy almost 100 times, and trialled every class of antidepressant available to him. To hear these clinical trial medicines that help patients make meaningful progress in just 2 to 3 sessions reinvigorated me with hope. I felt this was our only solution. Whilst Australia drags its feet, these therapies are being administered right now in places like Canada, USA, Switzerland, Israel, and other more progressive nations. Anthony, why should Australians have to break the law or travel overseas to access these safe and effective treatments when all else has failed? This is my lived experience. This is my reality. Sadly, my family will never get a chance to find out if psychedelic-assisted therapies could have saved my dear husband's life. My daughter and I will never know. Anthony, you can help put a stop to the immense suffering in this nation. Please reschedule these substances for therapeutic use. Please don't let another child lose a parent to suicide. In light of this, I request a personal meeting with you, my local representative, to express my concerns directly so that together we can find a way forward for all those suffering.
All right, well, Vanessa came to us, and she's an extraordinarily brave individual and is working closely with us on this whole drive towards having psychedelic therapies available in Australia for treatment-resistant patients on a controlled basis. The reason we showed that video up front was because it's very easy for us all to get into intellectual arguments about whether tests are satisfied or whether we have appropriate controls in place. And that's what the delegate deals with in the interim decision. But actually behind all the statistics, we'll look at real people. And many of those people are going through the most traumatic events. And we just want these therapies to be available as an option for psychiatrists and as an option for patients where it's appropriate. If we go to the slides, Scotty. All right, I'll just say a few words before starting to ask David some questions. But just to emphasize, we are very much in the regulatory clinical domain. So we have no interest in the illegal use of these substances. We want them to be part of the medical domain where there can be proper controls in place. We realise that there may be some people on the call who are very much involved in the recreational use of psychedelics. And whilst we respect that usage, it's really important that we focus on what is legal in Australia and we change the laws where that's necessary. And that's all about maximising our capacity to create change in this country. Next slide. I think many of you have seen this slide before, but it's worth reiterating that these are all numbers pre-COVID. Now, the 1 in 5 Australian adults with a mental illness, the 1 in 7 Australians on antidepressants, including 1 in 30 children. The fact that we have the second worst mental health statistics in OECD countries. Just a few days ago, the OECD came out with a data dump. And when you look at the data dump, what it shows is that over the COVID period, these already bad numbers have gone up dramatically. Now, for those of you who are clinicians, you will already know that because you'll be seeing the needs of your own patients. Listed down there at the bottom, some of the major mental illnesses, and the reason they're listed is because they happen to have been the focus of most of the psychedelic research to date. Next one, Scott. All right, now I've talked about the general population there, but when we get to our ADF veterans and our first responders, people who serve their country or have served their country in the most extraordinary fashion, what we see are mental health statistics that are a lot worse. You can see there, rates of PTSD, depression episodes, alcohol disorder, about 3 times the rate with veterans and the general population. Mental disorders generally about 2.5 times. Suicidal ideation about 10 times the general population, and comorbidity about 6 to 7 comorbidities about 6 to 7 times as high, making it much more complex to treat these people. With first responders, we're also seeing rates of mental illness which are significantly worse than the general community. And you'll see that 1 in 3 first responders suffer from high psychological distress, 1 in 10 suffer from PTSD. Suicidal thoughts, twice the general population. And unfortunately, 1 first responder taking his or her life every 6 weeks. So for this group of people, veterans and first responders, our hearts go out to them because, as I say, they do amazing work for us. And unfortunately, they're paying a very real price. Next slide, please. Now, when you look at these terrible mental health statistics that we have in Australia, there's really only 2 ways of getting those rates down. The first way is to really look at what's happening in our society to work out why Australia has such bad mental health statistics. And that requires a lot of soul searching amongst all of us, because there must be something wrong with our system that has led to those statistics. But the second way is to have better treatment options. And you'll see why there, because with depression, it's only about 35% of sufferers who go into remission. And I know a large proportion have some form of positive response, but positive response doesn't mean they're in remission. With PTSD, the numbers are even worse. It's probably less than 10% go into remission. And higher response rates, but a large proportion of people being rather glibly referred to as, in quotes, treatment resistant, terminology that hides enormous pain and suffering. So, if we're going to get these mental health statistics down, we've really got to be lateral in the approaches that we use, because existing treatments, whilst good for some people, for many people, aren't good enough for a large number of other people. Next slide, Scotty. All right, so let's get right now into the rescheduling timeline. You recall that we made a rescheduling attempt back in 2020, and that ultimately failed. But because of being further developments in the psychedelic sector, we lodged a new application in March of this year, which was published by the TGA in April. That led to a 4-week public submission period, which I'll refer to as the first phase of public submissions. And that in turn led to a meeting of the TGA's Advisory Committee on Medicine Scheduling, which is a very unusual beast because half the members were appointed by the Commonwealth, but the other half are appointed by individual states and territories around Australia. So it really is a Commonwealth state/territory body, and all of the state and territory representatives are public servants. And no disrespect for public servants, but I think it's sometimes harder to get independent advice on those sorts of advisory bodies when a public servant is the designate of his or her local, state or territory government. Then in October, the TGA published the delegates' interim decision. And as I mentioned before, that was against rescheduling. But the important point here is that the delegate had to publish the delegate's reasoning for that decision, or that interim decision. There were 9 propositions that the delegate made, and that gives us the opportunity to now go back and explain why those propositions are either wrong or should otherwise not inhibit the rescheduling of these substances on the basis proposed. We are now into the second phase public submissions period, which closes on the 24th of November, where everyone gets a chance to respond to that interim decision. So it's really important, if you disagree with it, that you lodge a submission with the TGA saying that you oppose the interim decision. And then we get a final decision in December with the actual implementation of the decision, if it's favourable, early next year. Next slide, Scotty. All right, now those first phase submissions that I referred to, we've seen a dramatic rise in the number of submissions compared to our first attempt back in 2020. And you can see it on this page. Back in 2020, in the first phase submissions, we had 575 for psilocybin and 478 for MDMA. That increased in the second stage public submissions process period to 728 and 605 respectively. This time around in the first phase, we've had about 13,000 submissions. So 6,650 for psilocybin and 6,505 for MDMA. And I want to thank all of you on this call who've taken the time to be part of that first phase process. You'll be glad to know that 98% of submissions were in favour of rescheduling. So an extraordinary number. You'll see in graphic form that massive increase in submissions. Next slide, Scotty. Now, when you break down the submissions that were lodged, it's really interesting because the TGA database, which we were able to access, breaks it down between professional researchers, healthcare professionals, patients, and others. And what you see there is that on the left-hand side with MDMA, you had 82 professional researchers lodging submissions. Now, 80 of those were in support of rescheduling, and they all named themselves. So you can publicly go through the list and see who they were. There were 2 against, and you're probably expecting this, but they didn't name themselves. And I have to say that intellectual honesty should be that when a researcher argues for and against, they should have the courage of their convictions and actually explain who they are. But on this occasion, they didn't. With health professionals, dramatically in favour of rescheduling. You'll see, virtually all the health professionals who lodged submissions said that these therapies should be rescheduled on the basis that we'd proposed. The same with patients, dramatically in favour of rescheduling, and the same with others. So all told, it's about 98% in favour for both psilocybin and MDMA when used as part of therapy on the restricted basis that we proposed. Next one, Scott. All right, now this is where it gets really interesting and where I'm going to invite David to come into the conversation, because with the delegate in the interim decision, the delegate came up with essentially 8 propositions as to why these therapies or these medicines shouldn't be rescheduled. And I should say they're currently in Schedule 9, which is the result of the war on drugs. Schedule 9, as most of you will know, is prohibited substances. We're seeking to move them to Schedule 8. In Schedule 9, despite its name, a psychiatrist can still get the approval of the TGA under the Special Access Scheme on a patient-specific basis to use these medicinal therapies. But, good old Australian federal system, in order to use the therapies, the psychiatrist with TGA approval also needs to get a local permit from his or her state or territory government, health department. And whilst these medicines are in Schedule 9, there are no permit systems available in any state or territory in Australia. So it really is stalemate for both the psychiatrist and the patient. They're gridlocked. If we can move these medicines to Schedule 8, then patient permit systems open up right around Australia. And what will inevitably happen, because it happens every time a medicine is rescheduled, the states and territory health departments will develop policies to support the approval process, and that's what we want. Now, I have to say that's the pragmatic reason for rescheduling, but when you look at the underlying data warrants rescheduling in any event. But with that, I might start going through the propositions made by the delegate and ask David to give his thoughts on those propositions. So, David, the first proposition is that there's insufficient evidence that MDMA or psilocybin, when used as part of therapy, has an established therapeutic value. And that's a critical test moving the medicinal therapies from Schedule 9 to Schedule 8. Give us your views on that statement.
Well, it really does hinge on what you mean by established. I mean, given that there are papers showing efficacy in the top journals in the world, so Nature Medicine for MDMA, New England Journal of Medicine, 2 papers for psilocybin for depression. It's hard to know how more established you could get than that. Now, they might be talking of, so clearly the scientific evidence we have is very strong. It's almost certainly going to be good enough with MDMA to get it licensed as a medicine in America next year. Now, I mean, I would argue the evidence is established enough, but they may be. I don't know what they mean by established, but certainly in terms of clinical data, which would be adequate to convince an ethics committee to do other studies or convince a psychiatrist like me to use these drugs clinically, then I don't think there's any question. The therapeutic value has been established.
Right, but you make a really important point there, and that is that established therapeutic value is not a scientific phrase. So you can't look at it and say, okay, it means scientifically X. It's the phrase where basically the delegate is applying judgment.
Yes.
And he or she is looking at the data and saying, based upon that data, it is or it isn't.
Let me put it another way, Peter. If we were talking about off-license use of a medicine, the usual criteria that are applied are that there is a significant body of medical opinion in favor of what you're doing. Well, a multi-center study of psilocybin, a multi-center study of MDMA, that is more than an established body of medical opinion. There's multiple centers of experts coming up with evidence of efficacy. So it is bizarre to say there isn't established therapeutic value. If by therapeutic value, they're meaning the same thing as what most therapists and doctors would believe, that there's enough evidence for it to be trialed in particular patients on a compassionate basis. It seems to me that has to be seen as, the case. That there's enough evidence there to I think, for any doctor to justify using it, particularly in treatment-resistant cases where the risk, so we'll come on to that, where other treatments have failed, and the benefits are likely to massively outweigh the risks.
Again, that's an important point, because with the rescheduling, because these are unregistered medicines, the only way they'll be able to be used is on a patient-specific basis with approval from both the TGA and the relevant health department of the state or territory where the therapy is to take place. So we're not talking about widespread usage yet. We're talking about usage for people who are treatment resistant. The system's not working for them, and the psychiatrist is concerned about their well-being. So it's and they have no other avenues, as we saw with Franco in that video.
I mean, it's very interesting, just reflecting on the video. I mean, it would be extraordinary to say that 96 ECTs was an established therapeutic approach, whereas psilocybin wasn't, given I don't suppose there's ever been a trial of 96 ECTs in someone with depression, but there's been a considerable number of trials of psilocybin. So, you know, we're clearly using double standards here. What people are doing, and obviously what they're doing is desperate to try to help someone, but the evidential base for the way Franco was treated with ECT is considerably less than the evidential base for not allowing him, you know, which they're denying for allowing him access to psilocybin. It really is. It's not unjust. It's actually, I mean, it's perverse and malicious, I would say.
David, by the way, Vanessa is on the call. So if you'd like to meet her, she'd love to say hello.
Vanessa, hi. Well, what, you know, thank you.
Vanessa, would you like to say hello to David and everyone?
Yeah, sorry, I've had problems getting through. I just want to thank everybody for listening to my story today and all the support I've been getting from everywhere. And I really feel very privileged to be able to share my story of my struggles with my beautiful husband, who, yeah, just, you know, for someone like myself who's very compliant with everything that the system has to offer, and to get to a situation where I was, I had nowhere else to go. It's, I feel this cause is very worthy, and I really hope that I can help make a difference by sharing the struggles that I had. And of course, with the ECTs, it is quite ridiculous because every single professor, I don't know if people know, but I sought help from every leading professor available to me, both at the Black Dog Institute and various other organizations. And every time they would be astounded by the number of ECTs that he had had. At that stage, it might be 40, it might be 50. But in the end, after they tried various medications, they again would apply more ECT to him, saying, well, we don't know why this works, but it works for people. So we're just going to have to continue giving him ECT. It's the only way. All it does is numb him and make his brain feel very fogged out. So yeah, I'm quite passionate about, you know, if sharing his story of someone that was so compliant, and because I'm a type of person that puts everything down on spreadsheets, I've got evidence of every single drug and the effects it has on people. And I was full time with him every day, in and out of hospital. Every day I was there. And so I saw a lot happening in the hospitals, and it concerned me greatly because a lot of these people lost their support network, because after a certain amount of time, it is difficult for someone to be around someone that's so severely depressed. It takes it out on you. But, you know, lucky I had a lot of support, and I just feel there's a lot of people in the system that are struggling and they're not responding to the current forms of therapy available to them. And yeah, when I heard of My Medicine Australia in 60 Minutes, I was really, really hopeful. And I still am for many, many people out there who I feel can survive this terrible illness that, you know, it's just not treatable by any other means, but hopefully by psychedelic forms of therapy. So I just want to thank everybody for your time.
Thank you, Vanessa, for being part of this. David, any comments?
Yes, well, I think Vanessa's highlighted the reason we're doing what we're doing, which is that what we've been doing up till now doesn't work for a significant proportion of people, and that leads to enormous burden on the person, and an enormous burden on the family, and to very high rates of suicide. And when you see close to your grasp a treatment which could change the trajectory of someone's illness dramatically with just one or two treatments, I mean, it does, you know, I just feel for patients who can't access it. It just seems so cruel.
It does. And just one thing I wanted to mention is Vanessa has this incredible dossier of every single medicine and treatment that Franco was prescribed. And Scott, if you could put a link to that so that some of the therapists and clinicians on this call can see what Franco actually did and how much effort and expense and suffering he had to go through over that 3-year period, I'd appreciate it, Scott. So you're on mute.
I should just said at the start that please come through the chat if you have any questions, and we'll particularly questions for David or Vanessa, and we'll attempt to have time to have them answered. David, the second one, which they keep raising, is risks versus benefits, and I find that intriguing given the safety data, but love your views on that.
Well, it's interesting, isn't it, the way they phrase it, risks versus benefits. That has always been the traditional way regulators have viewed medicines, and it's the wrong way. Medicines give you benefits, and then you should be considering benefits first and risks afterwards. But the fact they present it this way shows that they're biased in favor of finding risks rather than finding benefits. So that's just the first observation. In fact, we've now managed to get the European regulators to reframe their analysis as a benefit risk, which is as it should be. Look at the benefits first. So what are the benefits? Well, the benefits are that psilocybin is a single dose of psilocybin is the most powerful single dose treatment for difficult to treat resistant depression there's ever been. That's our study, and it's been replicated now by the Compass study. So benefits unquestionable. Great proportion of people given just one dose of psilocybin of a decent 25 milligram dose show a benefit, and significant proportion go into remission. Risks, well, in those two trials, there's almost no risk. In fact, when you look back at the history of psilocybin, it was a medicine in the 50s and 60s. There were very, very little evidence of harms at all. It's really important for people to realize that these drugs weren't banned because they were not effective as medicines. They weren't banned because they were harmful. They were banned because of the non-medical use, which was associated with the counterculture, particularly the anti-war culture, the anti-Vietnam War culture. These drugs were banned for political reasons. They weren't banned for health reasons. And the ban was utterly disproportionate to even the claimed harms, let alone the fact that there weren't so many. So the risks have been grossly exaggerated, and the benefits, as we're seeing now, have been deliberately minimized.
The third one we've got there is this question of optimal dose. Do we know enough now to, in a clinical environment, to know what level patients should be dosed at? How would you react to that as a risk, David?
Well, optimal is a very interesting question. Do we know the optimal dose of almost anything in medicine? No, what we know are that there are effective doses and ineffective doses. You'll never find an optimal dose from doing even RCT studies. So optimal dose emerges as clinicians get more and more experience. But what we do know is there is a dose which works, which is 25 milligrams of psilocybin, which is 100 to 125 milligrams of MDMA. That dose has very little in the way of side effects. It has very, very good efficacy, and that's good enough. And I think one of the things we need to really be very clear here. We're not saying we are going to force patients to have this treatment. What we're saying is, if patients, having been presented with the pros and cons, choose to have it and give informed consent, then they have a realistic chance of doing well. It's a decision that patients do have some autonomy over. So waiting for an optimal dose is really just, again, it's another example of procrastination.
Yes. Hey, David, Just a question, and Scotty, you might like to start interweaving some of the questions in the chat for David as well. So I'm going to ask you this one, David, from Craig. I think this is from you, Craig Ferns, I've got a feeling, but is there addiction risks associated with MDMA and psilocybin?
I should say, Tania, that's number 4.
Yes, sorry. Oh, okay, sorry. All right.
So
No,
Craig's
sorry,
question's
I shouldn't jump ahead.
right on to you.
Sorry, yeah, go ahead.
So
Go
the
ahead,
answer is optimal dose hasn't generally been established for the medicines that are being used today with depression. I mean, I could give you more examples. You can come back to me if you want more examples, but that's something that emerges with clinical use. But we have an effective dose, which is effective in the majority of people. That's pretty good, particularly as it's more effective than anything else we have, where we don't have an optimal dose for that either. So, this is again, it's procrastination, it's legalese rather than, anything clinically meaningful.
Yeah, and it's interesting, isn't it? Because we're getting involved in sort of, as you quite say, sort of legal stroke process arguments when there are real people suffering who could get the benefit of these therapies under the right controlled conditions.
Absolutely.
All right, the 4th proposition is the one that I think Craig's raised, and that is they keep coming up with this risk of dependence, and they seem to confuse, the difference between medical and recreational, but I think you'll have comments on both anyway, David.
Well, dependence on psychedelics is pretty much unheard of. So, I mean, even recreation, I mean, this is just a false premise. This is one of the assumptions that this is one of the lies that was told in order to get these drugs made illegal. And it's been one of the assumptions that people make, because having put them in Schedule 9, most people, the educated people, most pharmacologists, most doctors assume they are addictive, because why else would they be in Schedule 9? But they're not, they're anti-addictive. There are now multiple studies showing you can use psilocybin to break the cycle of addiction. This is going to be a revolution in the treatment of addiction. These are not addictive, even if they're used recreationally now. Yeah. Same is true of MDMA. I mean, when you look at the huge amount of MDMA use over the last 30 years, how many people have ever turned up to addiction clinics dependent on MDMA? Vanishingly few. And the reason for both these drugs not being addictive is because they work on largely through the serotonin system, which is an anti-addictive neurotransmitter, which is, one of the reasons they're also useful in disorders like OCD, which are kind of models of internal addictions to behavior. So absolutely, the risk of dependence is a complete red herring.
Now, there's a question on the chat, which is a great question, and that is who guards the guards? That is, who does the TGA report to? Can we call into question the TGA's ability to reach an unbiased decision? The reason it's a great question is that we have this, I think, perverse situation, and I don't know what it's like in the UK, David, where the decision is actually made by, advice is given by this committee I mentioned before, which is made up, half of them, by state and territory representatives. And we have no minutes of the meeting that are released, and we have no idea who voted and whether they said yes or no. So we don't have the position of New South Wales, for example, or Victoria, or any other state or territory. They then provide advice to the delegate. Now, the delegate actually is never named. We know he's appointed by the Secretary of the Department of Health, but he's never named. And so we don't know whether the delegate frankly has any pharmaceutical, pharmacology, mental illness expertise to make the decision that he's making. Now, I'm not in any way trying to denigrate the delegate. I'm sure the person is trying to do the very best that they can. But it does seem to me that if the delegate doesn't have the requisite mental health expertise, and particularly expertise in pharmacology, then it's going to be that person is much more vulnerable to suasion, which actually isn't based upon, which is based upon vested interests rather than suasion based upon good academic scientific research.
Totally, totally.
And I should also say that the delegate's decision can't be appealed against, so because it has the force of law. So I find it, as an Australian, living in what I think is a democracy, I find it a very bizarre set of circumstances. But that's one of my pet things at the moment.
Well, I think you've highlighted something very important, Peter, which is that the drug laws generally have been out with democratic decision-making. They've been made arbitrarily, but usually by secretaries of state for political reasons. And we certainly, my experience in Britain is that the laws persist because they serve a political agenda, not because they serve any health agenda.
Now, this next one I find intriguing, and that is that there are significant benefits for waiting for more clinical trial results.
Oh, yeah, you can't do because the drugs are so controlled, the clinical trials are very limited. However, there is good news. In other countries, the trials are going on. And now I think, hopefully, the Compass Pathways trial published a couple of weeks ago in New England Journal of Medicine, dose response trial in treatment-resistant depression, people who'd failed on between 2 and 4 previous medicines, showed good effect of the higher dose, the 25 milligram, that optimal dose. I would say that's the optimal dose. Same magnitude of effect as we showed in our first trial. So we've got a replication in a disorder like treatment-resistant depression, which is really quite unusual. So that's very satisfying. So I think the answer is, even if the weighting, even though I don't agree with the weighting, because I think the evidence was substantial before, I think it's even better now. So now we have, and this might be the get-off. This might be we can now perhaps persuade the delegate that actually that wait of a few months has turned out to be fruitful because it's another trial has come, which is, shows a very powerful outcome. But waiting, you can, until they, unless they actually said what exactly is the right number of patients to be treated in order to come to a conclusion, you could wait forever, couldn't you? There's always benefits for knowing more, but waiting without knowing that there will be more information is actually rather cruel. Anyway, the fact is there is more data which we can present to them.
I mean, the other thing there, David, is I would have thought it's a truism that virtually every psychiatric medicine will benefit by more clinical trials.
Of course.
But there comes a time when you've got enough evidence that actually the risk-benefit ratio comes out heavily in favour of giving a patient a chance.
Well, particularly, this is where the real missed opportunity is. If the rescheduling, if done correctly, if the rescheduling, if done in collaboration with a group like My Medicine, to create a national database, would dramatically, rapidly enhance the information we have, and would provide the clinical trial data or clinical results that we need in the real world. So we could actually turn this to this isn't just a question of helping people who are ill, but it's also a question of gout. We could use the rescheduling to massively facilitate our understanding and knowledge of the value of this medicine as well. It will be a win-win, a win for patients, a win for future patients.
I should say that part of our proposal was to fund a registry at Monash University, which they've agreed to run, which would be an independent. They go back to the registry and do what David's just talked about, build up the real world evidence support for these therapies. The next one, David, which Tania and I sort of anticipated right at the start, and that's training. That in order to do these therapies, you do need people who've been trained. And they do highlight that need, and we agree with it. But we've also developed a course in Australia, which now has 240 psychiatrists, psychologists, psychologists, and other health professionals who've been through it and graduated, which is designed to train clinicians in the use of these therapies. We've put lots of data about that in our rescheduling proposals. And never once has anyone from the health department or the TGA sought more information about the calibre of the training. Now, you actually see the training as a member of the faculty. How do you regard the calibre stroke competence of the training being provided?
Well, I certainly think in terms of the educational elements, it's actually outstanding. I mean, what they may be trying to hide behind is that you don't have enough people sitting in sessions with the apprenticeship model of training. But of course, that again becomes a circular argument, doesn't it? Because if people aren't doing the therapy, very difficult to get trained in the real world on it. No, I mean, it's again, it's a sort of vacuous comment. But the reality is, several things I would say to it. One is, if we waited for training, we wouldn't have started at all. How do you train on something? It's a chicken and egg. How can you be trained on something that isn't happening? So the training is rolling out therapy in a controlled way with therapists who are part of a registry is the best way to allow others to get trained. And I don't think there's any doubt we could provide support through international collaborations to facilitate people who want to learn and then get experience and also get debriefed afterwards with from the session. So it's again, it's a straw man. We have, there's enough experience, there's enough knowledge, and there's enough for people to actually start sensibly doing these interventions, I think.
Okay. And it's really like any new therapy, isn't it? I mean, any new treatment, you've got to actually make sure that people giving the treatment have been properly trained. It's sort of, it is part and parcel of our medical system. So this actually isn't reinventing the wheel here.
No, exactly not. No, but I think they're trying to say it is. And I mean, I think that's one of the few things, psychedelic therapy, of course, is very powerful, but the drugs are very powerful, but psychiatrists will be present administering the drugs. And the experience that people have under psychedelics, it's not something that's so different from what other disorders psychiatrists mean, like psychosis, like mania, people psychiatrists are trained to deal with people who are having powerful experiences. The great thing about the psychedelic experience is it is always short-lived, and then afterwards, the psychotherapeutic interventions that we don't know what the right ones are, the best ones are, but we know that it's necessary or definitely beneficial to have therapists present who can help people plot a new path in their lives. But I think that's largely the application of standard psychotherapeutic approaches that people are comfortable with and experienced in. So, and we got loads of trained psychotherapists. I mean, there's no shortage of those.
Just on that, David, there's a question that's just come through. We're doing a lot of telehealth at the moment, which arises out of the pandemic. And the question is, could the actual patient diagnosis and the prescription by the psychiatrist be done remotely, with the therapy obviously being done with people in the room? Is that a model, or is that too hard?
That's an interesting question. I certainly that I would like to have a pilot study of before I.
Okay. All right. So, Scotty, do you want to go to the next slide? Yeah, 7. I'll just speak to you very briefly, and that is that they're using the argument that states and territories don't have established mechanisms to provide controls in relation to applications received. Now, I've got to say, the pragmatist in me says, well, if you don't have established mechanisms, you should establish them, because if you've got people suffering, actually, you should be doing everything you can to make sure you support suffering people. So, to me, that's a complete red herring. And it's something, by the way, that health departments around Australia do all the time, establish new mechanisms as new medications come through. Risk of diversion for misuse. I'll just go through quite quickly on some of these, so we're conscious of time. Risk of diversion for misuse in the supply chain. Very strange comments by the delegate, because the delegate, unlike last time, has now accepted that the diversion risk is very small in a medically controlled environment. but it's argued, and you might be interested in this, David, it's argued that somehow upstream there are diversion risks. Now, it just seemed to me that if there are diversion risks upstream with these medications, then hey, what about fentanyl and OxyContin and a whole range of much more dangerous substances?
I have no idea what he's talking about. I mean, just complete bollocks, you know. I mean, absolute rubbish.
He then says that current regulation of these substances for therapeutic use abroad is consistent with the controls associated with Schedule 9 of the poison standard. That is, that's a half-truth, because in places like Canada, there is a special access scheme. There are provinces like Alberta working through approval mechanisms, and it's all been done in a very effective, efficient way. Whereas in Australia, yes, special access scheme is available for Schedule 9, but we have this perverse situation that if a psychiatrist got special access scheme approval and then took possession of psilocybin or MDMA to treat a patient, the psychiatrist, believe it or not, would be breaching recreational drug laws.
Yeah.
So it's quite perverse. The next one, scheduling is not an appropriate mechanism for establishing clinical governance, and in the case of psilocybin, rescheduling would bypass the processes for clinical trials. What do you make of that, David? I'm not sure I really understand it.
No, but I think I think what I suppose the interesting analogy is with medical cannabis, where the rescheduling allowed access that was demanded by patients and desired by doctors. And I don't see, I think the evidence for psilocybin is somewhat stronger than it was for medical cannabis. I mean, obviously there were some indications of medical cannabis like childhood epilepsy where they were very powerful, but they were quite rare disorders. The evidence for psilocybin in depression is very strong. So, and I think the point that he's missing the point, and this is something that really I do find very frustrating. Clinical trials come in many different forms, and making psilocybin available for compassionate use in a real-world trial where you do have all the patients entered into a database run by Monash would be a clinical trial. It would, but it'd actually be more useful than RCT because everyone gets it, so you get twice as many people getting the treatment, and it will be more inclusive because it could include people who currently are excluded from some of the other trials, for instance, because they failed ECT, which was an exclusion for the Compass trial. So it is a clinical trial.
Right, and look, the last one there relies on the views of the Royal Australian and New Zealand College of Psychiatrists and the Australian Psychological Society. APS is sort of interesting because their opposition seems to be against widespread use of these therapies at the present time. And we're not advocating for widespread use. We're actually advocating for very focused use of treatment-resistant patients. The Royal College of Psychiatrists is sort of interesting because as a peak body, they actually weren't set up to look after the interests of patients. Now, I don't say that with any disrespect, but they were set up to look after the interests of their members. Yeah. They produced a clinical memorandum where we don't know who the writers are. It was never submitted to their membership base.
Yes.
We know there are a large number of psychiatrists who support the rescheduling.
Yes.
So it's sort of this anonymous again.
My understanding, by the way, Peter, is it was never submitted to the New Zealand psychiatrists. I mean, I have many friends in New Zealand, some of whom work with psychedelics, and they never got any sight of this document. So it was like a little cabal of reactionary individuals who were doing their best to try to prevent innovation. I think I agree with you. I mean, it's you can't expect professional bodies to be very innovative because it means that they have to change the way they think. They're established not to do that.
Right. Now, look, I'm conscious that about time. So, Scott, if you go to the next one. And this is really the call to action, because we do need your help to really mount the very strongest argument with the delegate and the committee that now is the time for rescheduling.
Who said this? Is yours? Is that first bullet yours, Peter?
Yes. When I say experts, I'm not talking about you, David, by the way.
Well, that's what I was worried about. Yeah.
No, what I'm saying there is that, and maybe we should rephrase it better, is that we get these peak bodies come out and make these statements, but actually we don't know who's actually making the statement. Yeah. We don't know their expertise. We don't know the extent to which they've been reviewed, and we don't know whether there are hidden agendas. And it's all about that wonderful statement that the best form of disinfectant is sunlight. I mean, that should apply to this stuff. If people are going to make statements, or organisations are going to make statements, we want to see who's making the statement.
I agree.
And be able to assess the calibre of those individuals and their knowledge, and
that's
then compare it with your knowledge.
And that's interesting. You see, when you look at what happens in the States, everything is transparent. The hearings are public, and the public actually even have a right to ask questions, and that's probably why they're somewhat more progressive in getting medications available in their country.
Right now, in terms of what would love everyone to do on this call, and we'd love you to sort of spread the word amongst your colleagues and friends and acquaintances, is go onto our website and have a look at our submissions if you didn't do that in the phase 1 submission, in the phase 1 public submissions process. When I say look at our submissions, look at our applications, and look at the explanatory memorandum on the website, which explains how you make a submission this time around. So you go to the news tab, and then the TGA tab. You'll also find there the TGA's interim decisions, the documents that I've really broken apart in this discussion with David, and that will then there is then and Scotty, you might come in here because you've set this all up. So why don't you talk about what you then do?
For sure, happy to. And so the process for making a submission, as Peter has just mentioned, if you go to our website, and currently at the top of the homepage, there's a sort of a big banner there with a link which will take you to this page, which has links to all of the documents. And then from there, it'll link you through to the consultation hub that the TGA has set up. And if I go to the next slide, I believe it'll walk you through that. And it's a relatively straightforward survey to fill out. The first few sections ask for some individual details, and then it'll ask you to select one of these 4 categories, whichever one you fall into. But the main thing to bring everyone's attention to in making a submission, especially for those who did make one and in support earlier this year, is that the wording has changed. And so now the specific question in the survey is, what's your response to the interim decision? So please don't rush through and just click support thinking I support these therapies. The actual response, if you do support the therapies or you would like to see this rescheduling, is to oppose. So you'll see just here, you can just click oppose to oppose that interim decision. And then after that, just below it, you can add a written submission as well to share your reasoning. And that's whether it's based on your clinical experience or data, or whether that's the story, whatever is meaningful for you to share that as well as a part of your submission.
And also, Scott, if you could pop the link into the chat now, then everyone may in situ like to just already put their submissions in now, opposing, and then get all your friends and networks to do the same.
Yep.
We might just go to the last slide, because it takes us slightly away from rescheduling onto. Can you next slide, Scotty?
Yep.
Onto David's visit to Australia, and David, we're delighted to see you again. I mean, we speak to you often over Zoom and on the phone, but it really is very special having you here. The timing couldn't be better in terms of the rescheduling process. As I mentioned, David's got a public event in Byron this evening. we then go to Canberra over the weekend, and he's got another public event at the ANU, where he's giving a keynote address. Between that, he's meeting with regulators and politicians and other interested parties and stakeholders, other stakeholders. On the Tuesday, he's got the event at the ANU. Wednesday, he's in Sydney. And for those of you in Sydney, there's a public event at Paddington Town Hall, which is going to be fascinating. And so please come along to that if you can. And there's also other meetings that David that have been organised for David in Sydney. And then off to Melbourne. And there's a keynote address there for David at Monash University, where they're looking at generally at psychedelic medicines at the new Neuromedicines Discovery Centre at Monash, which Mind Medicine was very influential in establishing. He's then got a live event, which is a public lecture at Melbourne University. And there's also like a closing dinner or a gala dinner that's been arranged to end David's tour on Wednesday, the 30th of November. All of this is on our website under events. Tania, anything you want to add to that?
No, look, I just wanted to just encourage everyone to spread the word as far as they can, so that not only hopefully will we see lots of you at our events, and Professor Nutt would love to meet you all, but also because you know, the TGA is closing in just a few days, and whilst all of us on this call can put in opposing submissions, I just encourage you to, like Vanessa, I think, is reaching out to all of her family and networks, and I encourage you all to do the same, because when you think of it, we can really expand and really create change together. That's what a movement's all about. And, you know, we're a charity, and Peter and I are giving a lot of time and money, but we can't do this alone. It really is about a community demanding change here.
All right, just in closing, firstly, David, thank you very much for being part of this. So if on behalf of everyone, we can just give you a virtual round of applause.
Thank you very much.
And Vanessa, thank you for your bravery and being prepared to speak out and explain to people just how the medical system for treatment-resistant patients needs innovation and needs these therapies. And you did it in the most personal way. So thank you very much for that. And look, lastly, and it really relates to that last comment, you know, we've talked about arguments for rescheduling, and we've gone through all those 9 propositions. But the reality is that behind all these intellectual arguments are real people, and people who are suffering. Some of those people are suicidal, and unfortunately, some of those people will take their own lives. We will never get to the end point of research. There's always demand for further research. There's always a demand to understand things better, but we've clearly reached the time when we have enough data to say that these medicines can be used safely and effectively in medically controlled environment in a highly controlled way. And let's make sure that this time we get over the line so that Australia can really join a number of other Western countries and start making these therapies available to treatment-resistant patients on a case-by-case basis when they and their psychiatrist believe it's appropriate. So, Tania, anything you'd like to add at the end?
No, just a huge thank you to Professor Nutt and to all of you many of you who have been supporting us for ages. Thank you all. Thank you to all the donors on this call who support us. Thank you to all the clinicians who work tirelessly to try and heal their patients. Thank you to all the patients. Please don't give up hope. Please don't give up hope. We are doing everything we can, and we will never give up, and we'll keep fighting together so long as we can all support one another. Thank you.
Right. Thank you very much for being part of this webinar.
And see some of you at Byron tonight, I hope.
Yes.
Or Sydney, Canberra, or Melbourne.
Whenever.
Exactly.
Yeah, definitely. First, we kick off in a few hours. Yes.
Yeah, exactly.
All right.
Okay.
Bye-bye.